This maternity lecture is over Chapter 5, Nursing Care of Women with Complications During Pregnancy. You need to have your PowerPoint presentation, a writing utensil, and your book open to Chapter 5, which is page number 78. Let's get started. Your learning objectives are listed here for you. They are also listed in your book. The characteristics of high-risk pregnancies is that it relates to the pregnancy itself. It occurs because the woman has a medical condition or injury that can complicate the pregnancy, or it can result from environmental hazards that affect the mother and fetus. Also can arise from maternal behaviors or lifestyles that have a negative effect on the mother or fetus. So think about a case in which each of these would cause high-risk pregnancies. The fourth dot obviously is the easiest one. Maternal behaviors being that she abuses some sort of substance, or environmental hazards such as the mother is an X-ray technician and she has a high radiation exposure. So medical conditions such as diabetes, mellitus, those types of things. So be able to picture in your mind an example for each one of these characteristic causes of high-risk pregnancies. If you'll look at this picture, it's showing you what an amniocentesis is. An amniocentesis is an ultrasound-guided needle aspiration of fluid, the amniotic fluid in the mother's belly. It usually is collected and sent to lab, and they do a fetal assessment. There's some high-risk problems related to doing amniocentesis, so this would be up to the family whether they wanted one or not. You can see the needle and the ultrasound there. They want to make sure that they're getting it just into the amniotic fluid, not through the placenta, and obviously not hitting the baby. Nursing responsibilities include preparing the patient properly. These are nursing responsibilities for high-risk pregnancy. So we want the patient to be prepared for what's about to happen, for things that could go wrong. Explain the reason for the tests. This is specifically talking about amniocentesis. Why this is important for them to have. Remember, they can refuse the amniocentesis. And then clarify and interpret the results in collaboration with other healthcare providers. If you don't know already, nurses are not supposed to give results of diagnostic tests to patients. That's supposed to be a physician. However, when a physician comes and says something on a level that a patient can't understand, then we can definitely clarify and interpret what that physician has said. Another nursing responsibility would be to provide emotional support for the family. Danger signs in pregnancy, these are also listed on page 78 of your book in the patient teaching heading. A sudden gush of fluid from the vagina, vaginal bleeding, abdominal pain, persistent vomiting, epigastric pain, edema of the face and hands, severe persistent headache, blurred vision or dizziness, chills with a fever over 100.4, painful urination or reduced urine output. These 4 pregnancy-related complications we're going to go over: hyperemesis gravidarum, bleeding disorders, and there's going to be multiple of those, hypertension, and blood incompatibility between the woman and fetus. So hyperemesis gravidarum is the first one we're going to talk about. It is manifested by, so these are the signs and symptoms of excessive nausea and vomiting. It can impact the fetal growth. So if the mother isn't able to maintain any food, then the baby's not going to grow well. It can cause dehydration and reduced delivery of blood, oxygen, and nutrients to the fetus through the placenta. During the first prenatal visit, we're going to tell the patient the complications that we talked about on the prior slide so that they can identify any of these. The treatment for this is to correct any dehydration or electrolyte or acid-base imbalance. They may be given antiemetic drugs. Zofran or Phenergan are the drugs of choice. In extreme cases, they may have to be given TPN as total parenteral nutrition, and they may be hospitalized. Hyperemesis gravidarum may be related to the increased hormone levels the mother's body just can't handle. And the treatment is based on severity. So not everybody's going to get hospitalized in TPN. Some nursing diagnoses, if you can write down a couple of those that would be related to hyperemesis gravidarum, that will be helpful to you. Pause and do that for a second. Types of abortion. We're on page 83. So there are spontaneous abortions, and all of these are called abortions. Miscarriage is not a term that we use in healthcare. So spontaneous abortions mean that they have not done anything to encourage their body to get rid of the fetus. There are several different kinds. There's threatened, inevitable, incomplete, complete, missed, recurrent. Then the opposite of spontaneous is induced. We have actually done something to remove the baby. And that can be therapeutic or elective. I want you to pause the video for a second, write down the definitions of each of these found on page 83 in table 5.2. Now we're moving on to bleeding disorders, which was one of the pregnancy complications that we talked about. Nursing care of early pregnancy bleeding disorders. You're going to have early and late. So we're going to document the amount and character of bleeding. We're going to save anything that looks like clots or tissue for evaluation by a pathologist. Remember, this is early in pregnancy. It could be a spontaneous abortion, and they want to see if there's any particles that look like human bodies in there. The next one is perineal pad count. That is like a maxi pad, but they're a little bit bigger, and you estimate the amount of blood per pad. So let's say your patient, you come on shift at 7 and you're charting at 11, and your patient has had 5 bloody pads, and each of them have been 75% soaked with blood. That's completely different than your other patient 2 doors down who has had 2 pads with only 25% blood. That's how we estimate how much blood these people are losing. We're obviously going to monitor vital signs. And if they're Okay, so if the patient is actively bleeding, the woman should be kept NPO in case they need to take her to surgery. Here's some post-abortion teaching that you are going to need to know. Report increased bleeding. Take the temperature every 8 hours in case of infection. Take an oral iron supplement in case of anemia. Resume sexual activity as recommended. It's probably going to be 6 to 8 weeks before they're supposed to have sex. Return to the healthcare provider. We want them to be back so we can do their checkups, make sure that they're not having any complications because of the abortion. And then pregnancy can occur before the first menstrual period returns after the abortion procedure. So we want to make sure that we are focusing on birth control methods for these people. It's important just because your body usually isn't ready to be pregnant again that soon after a spontaneous or elective abortion. So the next pregnancy is not going to be healthy, or at least it won't start out healthy. Emotional care, I want you to pause the video and read the communication heading on page 85, and it says examples of effective communication techniques. Communication and emotional support is important for these patients because they've had a loss, whether you morally agree with it or not, and they need to be referred to community support groups if there are any to work through any grief of that pregnancy loss. So look through the emotional care and the experiencing pregnancy loss communication techniques and write those down. Ectopic pregnancy is the next thing that we're going to talk about. An ectopic pregnancy happens when the baby is implanted somewhere other than the uterus. 95% of those happen in the fallopian tubes. Things that this can result from scarring or tubal deformity, can cause hormonal abnormalities, inflammation, infection, adhesions. That's when two pieces of tissue grow together, congenital defects, and endometriosis. So here is a picture of the most common sites of ectopic pregnancies, and the little circles are implanted eggs. It can happen inside the ovary, all the way down the fallopian tubes, different spots in the uterus, the external os, and the cervical implantation, and then clear up in the GI system if you look right here. So things that can happen during an ectopic pregnancy. They could have lower abdominal pain and even have light vaginal bleeding at the very beginning. If the tube ruptures, and that's a fallopian tube, they may have sudden severe abdominal pain, vaginal bleeding, signs of hypovolemic shock, which we'll go over in a second. Shoulder pain may also be felt because that's referred pain. Treatment for this. We want to identify this pregnancy quickly. They will turn a positive pregnancy test. A transvaginal ultrasound is the one that goes inside the vagina to see where the implanted egg actually is. Laparoscopic examination to try to find if it's outside the uterus, outside the pregnancy organs. The priority is to control bleeding. 3 actions can be taken. You can refuse any kind of action because you believe that it's a baby. This hopefully has been caught before any heartbeats or anything like that to keep this from being a problem. They can treat it with methotrexate that inhibits cell division and causes the baby to be aborted. And then they can actually go in and do surgery to remove the pregnancy from a fallopian tube or wherever it's at. Here's another nursing tip. we're going to support and encourage the grieving process. Now look at that. It's support and encourage grieving. Because families who suffer a pregnancy loss, such as a spontaneous abortion or ectopic pregnancy, may have been trying to get pregnant, may have wanted a baby, and this allows them to resolve their grief so they can move on and try again. Here are the signs of hypovolemic shock. We have gone over hypovolemic shock, but it's good to remind yourself of these signs and symptoms so that you can identify them in your patients. They are fetal heart rate changes. You'll not know this unless you're checking. It could be increased, decreased, or a fluctuation, or less fluctuations, Rising weak pulse like tachycardia, rising respiratory rate tachypnea, shallow irregular respirations or air hunger, falling blood pressure, hypotension, decreased or absent urinary output. Remember, the normal is 30 milliliters an hour. If you don't know that, commit it to memory. You can't know what's decreased if you don't know the normal. Pale skin or mucous membranes, cold, clammy skin, faintness, and thirst. The next thing that we're going to talk about is a hyadroform mole. We are on page 87 if you're following along in the book. So a hyadroform mole is known as a gestational trophoblastic disease or a molar pregnancy. It happens when the chorionic villi increase abnormally and develop vesicles that resemble tiny grapes. It may be complete with no fetus present, partial, or only part of the placenta has these characteristic vessels. So this may cause hemorrhage, clotting abnormalities, hypertension, and possibly a later development of pregnancy. More likely to occur in women at age extremes in the reproductive life, so very young or very old. And they actually may experience signs and symptoms of true pregnancy. Manifestations include bleeding, rapid uterine growth, failure to detect fetal heart activity, signs of hyperemesis gravidarum, unusually early development of growth hormone, higher than expected levels of human chorionic growth hormone, a distinct snowstorm pattern on the ultrasound with no evidence of the developing fetus. Treatment would be uterine evacuation and dilation evacuation. So they're going to do a D and C. Bleeding disorders of late pregnancy. The first one is going to be placenta previa. So in placenta previa, we have an abnormal implantation of the placenta. If you'll look right here, this is the placenta, and this is the cervix. The baby has to come out of the cervix, unless, of course, they're C-section baby. But what happens is that the placenta is previous to the baby when the labor happens. So it comes first. Bright red bleeding occurs when the cervix dilates and results in painless bleeding. So, it's 39 weeks and your patient thinks that they're going into labor. They can feel the contractions and they start to dilate. This baby cannot come through the placenta. The placenta cannot be delivered first because the baby needs blood circulation and nutrients while they're going through the labor process. There can be 3 degrees of the placenta previa, so it can be marginal. It can be partial, so partially covering the cervical os, or totally covering the cervix. So abrupto placentae is when the placenta abruptly removes itself from the uterine wall. You could have normal implantation of the placenta. It could be on a place that is absolutely normal. However, you will have dark red bleeding with pain, enlarging uterus, suggesting blood accumulation in the cavity. If you look at the photo, the placenta is ripping off of its normal spot. So here's where the blood can accumulate inside the amniotic fluid or the uterine cavity. This is not planned and it is not normal. As soon as the placenta removes itself from the uterine wall, the baby is no longer getting blood and nutrition, including oxygen. If you'll look at page 88 on table 5.4, there's a comparison between placenta previa and abruptoplacentae. If you will pause your video and look at these different things, I would make a table so that I understood the difference between the two conditions. Complications and risks of the two placenta issues. Placenta previa can cause infection because it's an open wound, sort of, sitting in the vagina. It can also cause postpartum hemorrhage because of the lower segment of the uterus may have been attached. There aren't very many muscle fibers there, so only weak contractions may occur at that point, post-op or postpartum. Abruptoplacentae, predisposing factors. So things that may increase the patient's risk for this is hypertension, cocaine or alcohol use, cigarette smoking or poor nutrition, blows to the abdomen, so trauma, history of abruptoplacentae. Maybe they just can't make a placenta that works, or folate deficiency. Here's a nursing tip. Pain is an important symptom that distinguishes abruptoplacentae from placenta previa. Remember, abruptoplacentae, the placenta is just randomly dislodging, and blood is accumulating, there's stretching, all of that is painful. In placenta previa, the placenta is implanted in a place that is inappropriate, such as covering the cervical os. When the cervical os starts to open during labor, that's when the placenta is irritated and starts to bleed and causes problems. So that's normal bleeding, and they're in pain at the time. All right. So what are you going to do for a woman who has excessive bleeding? Obviously, we're going to document everything that is our lives now. But monitoring the vital signs closely, including the intake and output, is important. We're going to observe for pain, uterine rigidity or tenderness. We're going to order blood. We may order some typing and cross-matching. That is a blood lab that makes sure what the woman's blood type is, and they cross-match those antibodies that we talked about so that they can give them the correct blood. We monitor intravenous infusions. They're probably going to be on fluids, trying to keep them from being dehydrated from blood loss. They're going to prepare for surgery if that's indicated. We're going to monitor that baby. We want to know the fetal heart rate. We want to know contractions. Laboratory results that we need to monitor include coagulation studies. We want to know if this woman is going to be able to clot properly after all this bleeding. We're going to administer oxygen because decreased blood volume means decreased oxygen. However, the body needs more oxygen consumption because of all the trouble it's going through. The only way they can get that is by you administering it. We're going to prepare for newborn resuscitation. So when there is a complication, whether it's during an actual delivery or they assume a complication and you're just admitted not for delivery but to the maternity unit, they have alerted NICU. The NICU nurses are on call, sort of. So when the patient goes into labor or the heart rate goes down or the contractions do something weird, they will come to the bedside and be prepared to resuscitate the baby if that's necessary. So, moving on to hypertension during pregnancy, we are on page 90. So, hypertension during pregnancy is a high blood pressure. It's sometimes known as gestational hypertension. There are two types of that. It's called preeclampsia and eclampsia. You've heard these words before, but we've never talked about them in length. So we will do that. Chronic hypertension is a thing. Like, people have high blood pressure before they ever get pregnant. That's what that means. And then preeclampsia was superimposed chronic hypertension. So maybe the patient has chronic hypertension, but they're also preeclamptic because they are spilling proteins in their urine. So this presents before 20 weeks. So if they have chronic hypertension, it is present 20 weeks before pregnancy. Or if they have preeclampsia, there's a new occurrence of proteinuria or thrombocytopenia. An increase over the baseline of blood pressure, 30 milligrams per mercury or more systolically, or 15 diastolically. You need to know these so that you can tell. Risk factors for gestational hypertension include it's their first pregnancy. They are obese. They have a family history of gestational hypertension. The patient's age is over 40 or under 19. They have a multi-fetal pregnancy. There's more than one fetus. They have chronic hypertension, chronic renal disease, or diabetes mellitus. So manifestations of and systems affected by gestational hypertension. Obviously, they're going to have hypertension. With hypertension comes edema. Proteinuria means that when they pee, they're excessively losing proteins from their body. And then they can have blood clotting issues. They're going to have central nervous system issues such as a headache. Their eyes are going to be bloodshot or, just kind of tired or irritated. They can have urinary tract symptoms, respiratory symptoms, GI, and liver symptoms. So how are we going to measure gestational hypertension? That, of course, depends on the severity of the hypertension and the maturity of the fetus. Treatment focuses on maintaining the blood flow to the woman's vital organs and to the placenta. We want to prevent seizures or convulsions in this patient. Conservative treatment. So all the treatments that you're going to hear about, the physicians are always going to go for the conservative route first because we're dealing with a fetus in addition to the adult patient. So we're going to try an activity restriction. We're going to let the mom assess fetal activity. She can get a Doppler ultrasound, or she can count kicks, that kind of thing. We're going to monitor her blood pressure. She's going to do a daily weight, and they're going to check protein in the urine. That's something that you can also do at home with a dipstick. Drug therapy that we may use is magnesium sulfate. Remember that calcium gluconate, and you've already learned this, is the antidote for magnesium sulfate. Magnesium sulfate is going to stop the contractions or keep the patient from having early preterm labor. And then we're going to administer antihypertensive medications, blood pressure medication. The focus of your nursing care should be assisting the woman to obtain prenatal care, because she's going to have lots of visits that she wasn't planning on having, help her cope with the therapy because she's taken medications where she thought this was just going to be an easy transition into being a mother. This woman can be acutely ill, so we need to know what signs and symptoms to monitor for and when intervention is necessary. And of course, we're going to administer medications as prescribed. If you will look for me and pause the video after I'm done talking about this, on page 91 and 92, on 91, table 5.5 explains each characteristic of the hypertensive disorders very clearly, so I want you to write those down with their definitions. Then on page 92, I'd like you to write down the laboratory tests for patients with gestational hypertension. It's in table 5.6. So we have hemoglobin and hematocrit, platelets. The next thing that we're going to talk about are bleeding incompatibilities. These are important to understand. So the first thing we're going to talk about is Rh negative and positive. So when you talk about your blood type, you have A positive, A negative. That's the Rh negative or positive that we're talking about. The Rh negative blood type is an autosomal recessive trait. So the positive is going to be the dominant trait. There's an incompatibility that can occur if the woman is negative and the fetus is positive. This is red because it's important that you remember that the mother is negative and the fetus is positive. So what happens is the fetal Rh positive blood can leak into the mother's circulation. This can cause her body to respond by making antibodies that will destroy Rh positive erythrocytes, attacking the baby's blood. This doesn't have a problem in that very first pregnancy, but then when you have the second pregnancy and the baby's positive, the woman's antibodies against that Rh positive blood cross the placenta and destroy fetal Rh positive erythrocytes before the infant is born, which could cause a spontaneous abortion. So this is just a presentation of what it looks like if you need a pictorial presentation. So this occurs when the maternal Rh antibodies cross the placenta and destroy fetal erythrocytes. Remember, it's not going to occur in that first pregnancy, but subsequent pregnancies thereafter when the baby's positive. See the red statement? It requires RhoGAM. You must know the name of this medication. And it is given at 28 weeks and 72 hours of delivery to the mother. So that's 2 doses of RhoGAM, one given at 28 weeks of the pregnancy, and then within 72 hours of birth. You need to know that statement. If you have an amniocentesis, or if the woman experiences bleeding during pregnancy, they're also going to give a dose of RhoGAM at this time. Fetal assessment tests must be done throughout pregnancy to make sure that the body hasn't effectively gotten rid of what it feels like is foreign. An intrauterine transfusion may be done for the severely anemic fetus. We want that baby to be as healthy as possible. An intrauterine transfusion means that we are giving the baby blood through transfusion inside the uterus. Now, moving on to diabetes mellitus. I'm trying to catch up and see what page we're on, and that is page 97. Diabetes mellitus is different from gestational diabetes because it is preceded by the pregnancy. So we have diabetes mellitus before we have pregnancy. Type 1 is a pathologic disorder that they are not creating enough insulin for their needs. Type 2 diabetes is an insulin resistance or a genetic predisposition. Pre-gestational diabetes mellitus can be type 1 or type 2. Gestational diabetes is when you have glucose intolerance with the onset during pregnancy. So this may be the first time the patients had a problem with glucose intolerance, and it usually returns to normal 6 weeks postpartum. However, sometimes it doesn't, and the physician will assume that they just had undiagnosed diabetes mellitus, and they're just continuing through that disease process. The effects of pregnancy on glucose metabolism. So hormones like estrogen and progesterone and insulinase is an enzyme. These and increased prolactin levels have two effects. It can cause resistance of the cells to insulin and increased speed of insulin breakdown. So we're not able to use it quick enough because it's breaking down so fast. If a woman can't increase her insulin production, she'll have periods of hyperglycemia. So she'll have periods of very high blood sugar. Because the fetus is continually drawing glucose from the mother, she'll also experience low blood sugars in between meals and during the night. During the second and third trimesters, the fetus is at risk for organ damage from the high blood sugars because the fetal tissue has an increased tissue resistance to maternal insulin action. So we have possibility of creating lots of problems for the infant. One of the major risks is congenital anomalies to occur for maternal hyperglycemia during the embryonic period of development. These factors are related to gestational diabetes development. So these are risk factors. Maternal obesity, greater than 200 pounds, give or take the woman's height. A large infant. This is an important one. If you have an infant that is greater than 9 pounds, you are highly at risk for gestational diabetes in the future. A maternal age greater than 25 years, previous unexplained stillbirth, or infant having congenital abnormalities. Maybe they hadn't caught the gestational diabetes and it wasn't treated. That's why you have these problems. History of gestational diabetes in a previous pregnancy. Usually if you have it for one, you're going to have it for all your pregnancies unless you've lost a significant amount of weight. Family history of diabetes mellitus or a fasting glucose. Fasting glucose is the one where you haven't eaten for at least 12 hours, usually when you wake up from a good night's sleep. And if that is over 126 or post-meal glucose over 200, can indicate gestational diabetes. This is a baby that's over 9 pounds. That term in medicine is called a macrosomic infant. It's just a fat, chubby little baby. Treatment for gestational diabetes is diet. They will increase protein intake, decreasing carbohydrate intake. They'll monitor blood glucose levels at least 3 times a day, depending on the physician. They will monitor the ketones of the urine. They will encourage exercise in the patient. They will do fetal assessments really often to make sure that the baby's moving the way it's supposed to. Care during labor of the woman with gestational diabetes includes IV infusions of dextrose. If they can't keep the blood sugar where it's supposed to be, they may give regular insulin. It all depends on the situation, and they may need to assess the blood glucose levels hourly and adjust the insulin administration accordingly. That's a critical care situation. The care of the neonates whose mother had gestational diabetes. These babies may have hypoglycemia, low blood glucose, after the labor situation because they're used to really high blood sugars during the pregnancy, and then all of a sudden they don't have that. So their insulin's working overtime. These babies can also have respiratory distress. This is a situation in which NICU nurses are going to be at the bedside, and they will take them to the NICU until their blood glucose returns to normal. They may have an injury related to macrosomia. The most common injury related to macrosomia, being a big fat baby, is shoulder dystocia. That's when the shoulder gets caught on the pelvic girdle and they can't be delivered vaginally. Blood glucose is monitored closely for at least 24 hours after birth, and breastfeeding should be encouraged. Okay, so please pause your video after I get done telling you why. Go to page 97, box number 5-4, and look at the effects of diabetes in pregnancy. If you're an index card person, I would put the maternal effects of diabetes in pregnancy on one side and then list them on the other side, and the same thing for the fetal and neonatal effects down at the bottom. But you need to know those. That was on page 97. Okay, so now we're going to talk about heart disease, and that starts on page, sure does. Sorry. 101 down at the very corner. Manifestations of heart disease in pregnancy include increased levels of clotting factors, so that increases the risk of thrombosis. If a woman's heart can't handle the increased workload, because remember they have that increased like 5,000 mLs of fluid, heart failure can result. The fetus will suffer from reduced placental blood flow. Signs of CHF, congestive heart failure or chronic heart failure, depending on how old you are persistent cough, moist lung sounds, fatigue or fainting on exertion, difficulty breathing on exertion, orthopnea, severe pitting edema of the lower extremities or generalized edema, palpitations, and changes in fetal heart rate that could indicate hypoxia or growth restriction. Treatment: the patient's going to be under the care of both an OBGYN and a cardiologist. Priority care is going to be limiting physical activity, giving medications that include beta blockers, anticoagulants, and diuretics. Please remind yourself of examples of each of those medications. Vaginal birth is preferred as it carries less risk for infection and less respiratory complications, so therefore it's easier on the mother. Anemia is the next complication of pregnancy that we're going to talk about. It is the reduced ability of the blood to carry oxygen to the cells for whatever reason. There are 4 types that are significant during pregnancy, and we've talked about most of these already in Med-Surg. The first one is Iron-Deficiency Anemia, Folic Acid Deficiency Anemia, or Pernicious Anemia, remember. And then there are 2 genetic types, are Sickle cell disease and Thalassemia. So if you need a reminder about those specific disease processes, look at your disease process maps from Med-Surg. So the nutritional anemias, symptoms can be that the patient is easily fatigued, their skin and mucous membranes are pale, they have shortness of breath, a pounding heart, or rapid pulse, and that's usually with severe anemia. An iron deficiency anemia means that the red blood cells are too small and too pale to do their jobs. Prevention is given iron supplements. Vitamin C can help iron absorb into the body. Don't take iron with milk or antacid because calcium impairs the absorption. Treatment includes oral doses of elemental iron, and they usually continue this therapy for about 3 months after the anemia has been corrected. They need to be taught dietary increases in iron also, because dietary iron is absorbed better than synthetic iron supplements. Folic acid deficiency anemia is when large red blood cells are immature and they can't do their job because of that. Anticonvulsants, oral contraceptives, sulfa drugs, and alcohol can decrease the absorption of folate from their meals. So if they're on any of these or do any of these things, they're already at risk for folate deficiency. Folate is essential for normal growth and development of the baby. So remember that folic acid is going to prevent neural tube defects in your baby. Down here is the amount that you take per day, and you do need to know this. So folic acid supplementation is 400 micrograms or 0.4 milligrams per day. Treatment, folate deficiency is treated with folic acid supplement, usually 1 milligram a day over the amount of the preventative supplement. So your prenatal vitamins should contain folic acid. There are brands that do not. That is why people need to take the prescribed prenatal vitamins from their doctor. The dose may be higher for women who've had a previous child with a neural tube defect to try to prevent that in a subsequent pregnancy. Sickle cell disease is an autosomal recessive disorder. It is abnormally shaped hemoglobin. It causes the erythrocytes to be distorted into a sickle cell or crescent shape, and it can cause hypoxic or acidotic episodes. The abnormally shaped blood cells don't flow smoothly. It can clog small blood vessels. Pregnancy can cause a crisis. You know that they have sickle cell crises in this disease process, and pregnancy is a trigger. Massive erythrocyte destruction and vessel cell occlusion can cause risks to the fetus, because occlusion of the vessels that supply the placenta may be affected. This can lead to preterm growth issues, growth restriction, and fetal demise. That's death of the fetus. Oxygen and fluids are given continuously throughout labor. Thalassemia is a genetic trait that causes abnormality in one or two chains of hemoglobin. It's usually most often seen in the beta chain inside the United States. They can inherit an abnormal gene from each parent, causing beta thalassemia disorder. If only one abnormal gene is inherited, the infant will have beta thalassemia minor. So either the mother or the infant can be affected. The mother's going to have few problems, but mild anemia is going to be one of them. And the fetus doesn't appear to be affected at birth. Iron supplements may cause iron overload because the body absorbs and stores iron in a higher than usual amount. It's kind of the opposite of what we've been talking about. So nursing care for anemias during pregnancy, we want to teach the patient what foods, like I told you, are high in iron and folic acid. So if you don't remember those, please look back at your med-surg notes and review. Teach the patient how to take the supplements. Supplementation should not be taken with milk or any type of calcium supplement and acids. They should be taken with vitamin C. When taking iron, the stools are going to be green, dark green, or black. The woman with sickle cell disease is going to require lots of medical care and nursing care. They need to be taught to prevent dehydration or prevent activities that cause hypoxia, because that can cause a crisis. Avoid situations where exposure to infection are likely, and report any signs of infection promptly. Here is a handy-dandy mnemonic phrase for infections. It's called TORCH. The T meaning Toxoplasmosis. The O is for other. R is for Rubella. The C is for Cytomegalovirus, and the H is for herpes. These infections can be devastating to the fetus or newborn. Viral infections usually do not have effective therapy. We're on page 104, by the way. Immunizations can be given to prevent some infections. A woman who is pregnant needs to have updated immunizations. Cytomegalovirus is the first one that we're going to talk about. It is a widespread infection and commonly occurs during childbearing years. It's often asymptomatic in the mother, but the infant has issues. The infant can have mental retardation. Okay, so cytomegalovirus may cause issues for the infant. However, the infection is really common during childbearing years, and the mother may actually be asymptomatic and not know she has it. The infant can have mental retardation, seizures, blindness, deafness, dental abnormalities, and petechiae. Treatment. There is no effective treatment. Therapeutic abortion may be offered if cytomegalovirus is discovered early in pregnancy. And they actually test for this early in pregnancy because of all these things. Rubella. This is the R in your MMR shot. So everybody in the room should be immune to it, but is a mild viral disease with a low fever and rash. But the effects on the developing fetus can be very destructive. If the woman receives a rubella vaccine prior to pregnancy, she shouldn't get pregnant for at least 1 month. I'm pretty sure that that's a test question. It is not given during pregnancy because the vaccine is a live virus and could affect the fetus. The effects of the fetus or the embryo include microcephaly, which is small head size, mental retardation, congenital cataracts, deafness, cardiac effects, and intrauterine growth restriction. Herpesvirus, which we've talked about before, it can have one of two types. Type 1 is likely to cause fever, blisters, or cold sores, and type 2 is likely to cause genital herpes. After the primary infection, it does lie dormant in the nerves of your body and can be reactivated at any time. Excuse me. The initial infection during the first half of pregnancy could cause spontaneous abortion, intrauterine growth restriction, and preterm labor. The infant can be infected in one of two ways. It could be localized, disseminated, or have a high mortality rate. The treatment and nursing care is to avoid contact with lesions. The mother and the infant do not need to be isolated as long as direct contact with lesions is avoided. Breastfeeding is possible if no lesions are present on the breasts. Hepatitis B is transmitted through the blood, saliva, vaginal secretions, semen, and breast milk. It can also cross the placenta. The fetus may be affected transplacentally or through contact with blood or vaginal secretions during delivery. Upon delivery, the neonate should receive a single dose of the hepatitis B vaccine, followed by, immunoglobulin, and then followed by the vaccine. Hepatitis B vaccine will be the first vaccine that the infant gets. Risk for hepatitis B includes intravenous drug use, multiple sex partners, repeated infections with STIs, occupational exposure to blood products and needle sticks, so healthcare workers, hemodialysis, multiple blood transfusions or other blood products, household contacts with a hepatitis carrier or a hemodialysis patient, contact with persons arriving from other countries where there's a higher incidence of hepatitis B. Human immunodeficiency virus is HIV. It is the virus that causes AIDS. It cripples the immune system, and there is no known immunization or curative treatment. You can acquire HIV in one of three ways: sexual contact, parenteral or mucous membrane exposure to body fluids, or perinatal exposure. The infant may be infected transplacentally, so through the placenta, or through contact with infected maternal secretions at birth. It could even transfer through breast milk. Nursing care about HIV. We want to educate the HIV positive woman on methods to reduce the risk of transmission to the developing fetus or infant. Pregnant women with HIV or AIDS are more susceptible to infections. Remember, infections usually cause the demise of patients with HIV or AIDS. Breastfeeding is absolutely contraindicated in mothers who are HIV positive. Toxoplasmosis is the next one we're going to talk about, and it is a parasite. It is acquired by contact through cat feces or raw meat. It's transmitted through the placenta. It causes congenital issues like low birth weight, enlarged liver and spleen, jaundice, anemia, inflammation of the eye structures, neurological damage. Treatment is therapeutic abortion. Do you hear that? Treatment is therapeutic abortion. This is a big deal. Preventative measures include cooking all meat thoroughly. This includes lunch meats, hot dogs, all of the things. Wash hands and all kitchen surfaces after handling raw meat. Avoid uncooked eggs and unpasteurized milk. That's why we don't eat queso. Wash fresh fruits and vegetables well. Avoid materials contaminated with cat feces. Group B, Streptococcus infection. It's the leading cause of perinatal infection with a very high mortality rate. It's an organism that's found in a woman's rectum, vagina, cervix, throat, or skin. The risk of exposure to the infant is greater if the labor is longer and the woman experiences premature rupture of membranes, because things are open for business longer. Group B, Streptococcus is a significant cause of postpartum maternal infection. They usually test for this early and treat it early in the pregnancy. Symptoms of postpartum infection include elevated temperature within 12 hours after delivery, rapid heart rate, abdominal distension. It can be deadly to the infant, and the treatment is as simple as penicillin. Tuberculosis is another infection that we're going to talk about. It has an increasing incidence in the United States. It is multi-drug resistant strains. Those are increasing as well. The mother can be tested via skin test. If positive, they require a chest x-ray and possible sputum specimens. They report to the local health department if they have active tuberculosis. And if the mother is active, the infant must be kept away from the mother until she's cleared by the public health department. Sexually transmitted infections are common in pregnancy. The mode of transmission is sexual intercourse. You get them the same way you get a baby, right? Infections can be transmitted, such as syphilis, gonorrhea, chlamydia, trichomonas, and condylomata acuminata. Vaginal changes during pregnancy increase the risk of transmission. So urinary tract infections are also a common infection during pregnancy. The pregnancy alters the self-cleaning action of the vagina and the urinary structures, and it sometimes prevents the bladder from emptying completely, so we have urinary stasis. That retained urine becomes more alkaline and allows bacteria to grow. They may develop cystitis, which can be signs and symptoms: burning on urination, increased urinary frequency and urgency, and then normal or slightly elevated temperature. There's also the problem of polynephritis if it goes to the actual kidney, pyelonephritis, however you want to say it. It's a high fever. You get chills, and you have flank pain because it's your kidney or tenderness, and nausea and vomiting. Environmental hazards during pregnancy include bioterrorism. 3 basic categories are: A, can be easily transmitted from person to person; B, can be spread via food or water; or C, can be spread through manufactured weapons designed to spread disease. And then there's substance abuse. Questions should focus on these things to help nurses and physicians provide the safest and most appropriate care for the woman and her infant. And then alcohol. A single episode of consuming 2 alcohol drinks can lead to some fetal brain cell abnormalities. Trauma during pregnancy is a problem also. The 3 leading causes of traumatic death include automobile accidents, homicide, and suicide. You'll want to assess your patient for battering or any type of familial violence, bruises, cuts, stages of healing, that kind of thing. If a woman confides to you that she's being abused during pregnancy, it must be kept confidential. Her life may be in danger if her abuser learns that she's told anyone. She should be referred to local shelters, but the decision to leave her abuser is hers alone. Effects of a high-risk pregnancy on the family. It is a disruption of usual roles. Sometimes the mother will not be able to work or do any of the things that she's expected to have done. They may have financial difficulties because of this also. They have delayed attachment to the infant because they've been in the NICU or separated from the infant, or maybe don't even have the energy to deal with it. There is a loss of the expected birth experiences because they expect everything to be happiness and rainbows. There is a frustration with activity restrictions. Maybe they have other children to take care of. And then there's an alteration in child care practices if the patient is on bed rest even after the infant comes. Maybe she can't take care of the baby and has to get help with that. Interventions for the grieving process. You want to allow the patient or the parents to remain together in privacy, accept behaviors related to grieving, develop a plan of care to provide support for the family, offer a memento such as a footprint or handprint, offer parents an opportunity to hold the infant if they choose to, prepare parents for the appearance of the infant. A preterm infant's not going to look like a chubby baby. Provide the parents with educational materials and referrals to support groups. Discuss the wishes of the family related to their cultural issues and whatnot. Make sure that you review the objectives, all of your key terms, any key points. I do want you to look at your book with me for a second. On page 110, table 5.9, there is a substance harmful to the fetus table. I need you to read over that and know these substances. Things such as ACE inhibitors, Accutrel or vitamin A, things like this you need to know for care of your patients. If you haven't read your chapters, you need to do that. The test will be over chapter 4 and 5. There's also a table. There's tables all over this chapter, which I love, but a specific page that I would like you to look at that we haven't discussed is page 84. And these are, this table is 5-3, and it's the procedures used in pregnancy termination. There's vacuum aspiration, dilation and evacuation, RU486, methotrexate, prostaglandins, and a hypertonic uterine infusion. I need you to read that table, be familiar with these concepts. They can be found on YouTube if you want to watch them. I don't suggest it because it's pretty graphic. And then if you will go to page 80, 81 and 82, Table 5.1 are fetal diagnostic tests. You need to read over these and understand what they are. If you're an index card person, I would put one on an index card and the explanations on the back. And that concludes our video lecture for Chapter 5. Remember, Chapter 4 that we went over in class is also on this test. This will be your first maternity test, so study, study, study.